Gender-affirming care is a cornerstone of multidisciplinary health support for transgender and non-binary people. But the political landscape in the United States poses escalating challenges for transgender health, including for access to gender-affirming care. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Alex Keuroghlian, an associate professor of psychiatry at Harvard Medical School and director of the Division of Public and Community Psychiatry at Massachusetts General Hospital. Dr. Keuroghlian has co-authored a perspective article about policy threats to protections for transgender and non-binary people. Dr. Keuroghlian, what types of interventions are included under the umbrella of gender-affirming care?
Gender-affirming care includes a broad range of interventions. I should say, first, there's psychological gender affirmation, which involves gender identity, exploration, discovery, and self-acceptance. That can be with the help of a clinical psychotherapist, for example, with support from one's community or on one's own. There's social gender affirmation, which may involve things like changing your name, your pronouns, the way you dress, your hairstyle. There's chest binding, genital padding, genital tucking, for example. There's legal gender affirmation, which involves changing gender markers on official government-issued documentation, like a driver's license, passport, or social security number. There's medical gender affirmation. It should be said there are no medical or surgical interventions performed for young children, contrary to a lot of disinformation that's out there. In early puberty, 10 or stage 2, there's the possibility of initiating pubertal suppression with gonadotropin-releasing hormone analogs like leuprolide that temporarily press pause on development of secondary sex characteristics in order to determine with the patient, family, and care team whether it's appropriate to move forward with gender-affirming medical care. It should be said if you discontinue pubertal suppressants, endogenous puberty proceeds as it otherwise would. These pubertal suppressants are also FDA approved and widely used already for things like central precocious puberty with a very good side effect profile. Then there's a possibility later in adolescence or at any point in adulthood of initiating gender-affirming hormone therapy with a testosterone or estradiol-based regimen to induce secondary sex characteristics that do align with the patient's gender identity. Finally, there's gender-affirming surgery. This is typically performed in adulthood, and that includes a range of procedures, not just the genital surgeries people often think about, like a phalloplasty or vaginoplasty, but also facial surgeries, chest surgeries, and gonadal surgeries.
So, what's known about the effects of all these interventions and about the consequences of denying gender-affirming care?
Well, we've done a number of studies, other people have as well, comparing people who have accessed gender-affirming interventions, including social gender affirmation, gender-affirming hormone therapy, pubertal suppression, gender-affirming surgery, gender-affirming hair removal, for example, and shown that access to these compared to desiring and not accessing these is associated with better mental health in adulthood, including things like decreased odds of suicide attempts, suicidal ideation, at-risk substance use, and other mental health effects depending on the particular intervention. We see different kinds of benefits in terms of mental health outcomes.
As you say in your perspective article, some states have imposed restrictions on gender-affirming care for transgender and non-binary young people. How widespread are those restrictions, and what reasons have policymakers given for enacting them?
We have restrictions now in 26 states across the US on gender-affirming medical care, particularly for youth, for minors, although there are now clear efforts to also restrict access to gender-affirming medical care for adults. And the arguments given are often disinformation-driven narratives. One of these is the false notion that people are likely to regret having pursued gender affirmation and to voluntarily discontinue this at some point in the future. We did the largest study on this, showing that, first of all, discontinuation of gender affirmation is rare. And in the rare instances where this happens, it's almost always due to external factors like family pressure, community pressure, incarceration, joining the military, moving and losing access to your gender-affirming medical providers. It's rarely due to fluctuation in or doubt about your own gender identity. And other studies have shown that in the rare instances where people do voluntarily discontinue gender affirmation, they're quite unlikely to have regretted it. They view it as part of their gender journey and what helped them clarify and consolidate their gender identity. That's one disinformation-driven narrative that's been woven into efforts to restrict access to gender-affirming care at the state level. Another disinformation-driven narrative is this idea that if you are clearly trans or gender diverse from the time you're a young child, that's a more legitimate and lasting gender identity. However, if you're first realizing this as a teenager, that's likely to be due to what people refer to as social contagion and as more transient identity that's not going to last into adulthood. And we did a study showing that, first of all, 40% of transgender and gender diverse adults in the US first realized they were transgender as teenagers. So clearly, that's a huge proportion of transgender and gender diverse adults. And those identities, by definition, persisted well into adulthood. We also looked at the median time that passes between when someone first realizes they're transgender or gender diverse and when they first disclose this to another person. We found that that median time was 14 years that passed. So it may be rapid onset news to parents and families that their loved one, child is transgender or gender diverse, but that person has typically known for years and has been building up the psychological safety to tell another person.
In your article, you specifically mentioned Tennessee's ban on gender affirming care for transgender young people, which has reached the Supreme Court of the United States. In the United States versus Grometti case, what are the facts of that case?
The Grometti case was heard at the Supreme Court in December of 2024. And I'm cautious here because I'm not an attorney. One of my co-authors for this New England Journal of Medicine perspective is a law professor at Harvard Law School, Alexander Chen, who's much better equipped to speak to this than I am. That being said, the basic issue at hand is a law in Tennessee that restricts access to pubertal suppression and gender-affirming hormones for transgender and gender diverse youth, even though these same interventions are permitted for cisgender people. So at the core, there's a discrimination issue. The arguments were heard in December of 2024, and we'll see what happens in 2025 in terms of a decision from the court.
What do you think the implications of that decision are going to be?
Well, hopefully the finding will be that the Tennessee law is discriminatory and unlawful. If, unfortunately, the decision is that this law is not discriminatory, then I fear we'll see more restrictions on medically necessary evidence-based gender-affirming care in the United States and in potentially additional states where such restrictions don't yet exist at the state level.
And then on the federal level, what policies have been implemented or are moving forward that could affect the health and well-being of transgender and non-binary people?
Well, until January of 2025, there was a set of federal policies strongly in support of gender affirming care as evidence based medically necessary care. And that position of the US federal government was consistent with stances taken by the American Medical Association, the American Psychiatric Association, the American Academy of Pediatrics, the American Psychological Association, the Endocrine Society, and the Pediatric Endocrine Society. So there's a clear consensus within the mainstream of medicine that this is necessary and evidence-based care. More recently, from the federal government, we've seen executive orders that fundamentally claim that there are only two sexes, male and female, in the words of the first executive order on the topic that was issued on Inauguration Day. And subsequent executive orders restricting rights, freedoms, health access for transgender and gender diverse people are based on that false notion. We know even at a biological or physical level, humans exist with variations in physical sex development that don't fit neatly into traditional categories of female or male. These variations in physical sex characteristics are much more prevalent than some people may realize. And these are things that we all study in medical school. In fact, there's an intersex health rights movement based on the reality that there are people with these variations in physical sex characteristics. We also know that gender identity for a given person does not necessarily align with society's expectations based on the sex they were assigned when they were born. The goal of these executive orders is to erase the existence and experience and needs of transgender and gender diverse people, intersex people, people with variations in physical sex development. And this really threatens the well-being of these communities and populations, concretely, directly restricts access to much-needed health services.
Finally, what steps can healthcare practitioners and institutions take in the current political environment to support the health of their transgender and non-binary patients?
Healthcare professionals and institutions can rededicate themselves to providing evidence-based medically necessary care for people of all gender identities, can establish and strengthen referral networks within the state or out of state in order to ensure that patients have timely access to gender-affirming care. Practitioners and healthcare institutions can also get involved in health advocacy to inform policy at the organizational, local, state, and federal level.
Thank you, Dr. Keuroghlian.